of U.S. Hunger, and today our conversation is presented by one of our longtime partners and friends in the fight against hunger, J.P. Morgan Chase. So glad to have them on board in this conversation series. And I'm especially excited about today's discussion and our topic, improving outcomes. And the conversation I think you'll find is unique in that its focus is on collaboration between community organizations and the healthcare sector, but from a data-driven approach, which I think is a bit unique. And we're teaming up with HIMSS, the Healthcare Information and Management Systems Society. Glad to have them on board, as today's program is approved for up to 0.75 continuing education hours for use in fulfilling the continuing education requirements. And you'll see more information on that throughout the series today. Joining me today on this panel are leaders in their own right, but also partners in our mission and stakeholders in our organization's evolution. So first up is Ezekiel Brooks. Ezekiel is the Chief Technology Officer at U.S. Hunger, with nearly 30 years of experience designing, developing, and implementing software solutions for Fortune 500 companies of the likes of Disney, Sony Ericsson, and NCR. And over the past year, Ezekiel has worked tirelessly to build a hunger SaaS platform here, enabling U.S. Hunger and its partners to fight hunger and food security with a new weapon. And we're excited about it: technology and just-in-time data. Ezekiel, it's good to have you here.
Thank you so much, Rick.
Next is Michael Wood. Michael is the Chief Strategy Officer at Insighten Health, and an amazing voice, which you'll hear in a minute. Michael brings 20 plus years of experience in consulting, technology implementation, and business analysis for various direct-to-consumer industries. Michael's deep insight in Medicare Advantage marketplace provides Insighten with a strategic view from the health plan's perspective. Michael, it's good to have you on board.
Good to be here, Rick.
Love that voice. And next, certainly not last or least, but Carissa Steinrei. She is VP of Clinical Strategy at Insighten Health, and Carissa brings over 15 years of healthcare experience on both the delivery and the payer side. A social worker by background, she's very passionate, and a passionate clinician, I think you'll find, who understands the need for technology and innovation for improving the health and wellness of the community at large, one individual at a time. Carissa, it's good to have you here as well.
Great to be here. Thanks, Rick.
For those that may not know U.S. Hunger, we're a 501c3 impact organization, as I like to call us. And our mission is feeding families today and uniting them to a healthier tomorrow. And like many, the COVID pandemic of 2020 caused us to think differently. No longer was it just important, after more than a decade, to know how many we were able to feed, but rather to understand why are they hungry in the first place. And to do that, we shifted our focus and invested heavily in technology and focused on data and client engagement. And today's conversation will center a lot around that topic. We had to learn to listen and ask questions first, and then just let the voice of the families we serve inform just how we help. So take a look behind the scenes real quick before we start.
What would happen in crisis if we took the time to listen?
As a recent cancer survivor, I am in continued treatments every 3 weeks, so nutrition and vitamins are of the utmost
Our
importance.
food supplies have dwindled over the past few months. I have suffered from diabetes for over 14 years and required healthy foods including proteins, fruits, and vegetables to maintain proper blood glucose
The inability
levels.
to work due to poor health, combined with mounting medical costs, have made obtaining nutritious meals difficult.
Fresh fruits and vegetables are so important to maintain good health and to reduce the flare-ups of the chronic health conditions in our household members.
We're listening. We're learning. We're responding. At US Hunger, we engage every client to have deeper conversations and gain a fuller understanding of the socioeconomic factors that determine health. Dignity and discretion are the foundational principles behind our work, and we believe everyone deserves a quality experience that says, you are worth it.
A full cart box will help provide food security.
This would be very much appreciated.
May God bless
Thank you so much for all you do.
To learn more, visit ushunger.org today.
I love sharing that video. What you just saw was a representation of actual stories we see and read on a daily basis here at US Hunger. And our investment in technology has enabled us to access a new level of impact. It has shown us that you can't address why someone is hungry until you understand their experience. Something that I believe CMS is putting an emphasis on in how we provide care. We were missing that point for so many years, ignoring exactly what was driving their experience. So, Michael, I want to start with you. As you put it in a blog not too long ago, and yes, we are following you, personalization has long been the holy grail of healthcare. What have you observed at Insight and the larger marketplace in regards to member experience?
Great question, Rick. I think in terms of the kind of overall experience, it's definitely changing. There's a lot of factors that build into that. I think obviously the changes around regulation and certainly things like STARS measures where the weighting's increased to put more of an emphasis now on experience and joining that together. I think what we've really seen here is an evolution from, in the early days of the quality programs, kind of the low-hanging fruit around closing gaps and, HEDIS measures and things. And now it's actually the tough nut to crack, which is experience. And for that, it's going to require a much more connected ecosystem to really understand each person, down to their community, street level information to be able to really serve them well in their healthcare going forward.
That question is a great segue to you, Ezekiel. How has technology and data allowed US Hunger to build what I hear you often call dignity into our actual client experience? What's the role of technology here in that?
Well, certainly technology end to end for us here at US Hunger. It starts in our technical creatives. It ends with our technology, software developers and engineers. But dignity and discretion are our two core pillars in everything we do. Everything from giving a first-class experience with, on the level of a Blue Apron or a HelloFresh. We want to make sure that the technology enables us to provide top shelf customer service and those sorts of things. That any collateral they get is just magnificently done because of technology, right? Any emails, text, any kind of follow-up, status, top shelf, done with technology. But as we dig a little deeper into it, it's more than just the bells and the whistles on the outside. Data is the engine that drives our understanding of how to really give a voice to the voiceless. On a technical level, we have, last count, we have nearly 80,000 surveys done in the last 18 months digitally with technology. Not only do we ask sort of yes/no questions and choice questions, but we give our applicants and people that are needing our help, we give them a way to express their whole story, uninhibited, uncut, unfiltered. Things that they normally wouldn't tell a professional provider of some type, a clinician or a social worker. We found that people will tell us the whole story that backs the data that we're seeing. So we use machine learning, natural language processing, artificial intelligence shortly. And this data is speaking with a very loud voice about why are people hungry in the first place? It's more than food. And some of the reasons why they're hungry, Rick, they're very surprising. I mean, Michael and I are going to do a dive into an area of the country that we both agreed to take a mutual look at, and we're just going to organically compare our findings live. So it's very important that we use technology for good. to tell a story and to give a voice to the voiceless.
Yeah, I think I often hear you say that is digitizing dignity, and I love that phrase. I'm going to give you credit about 2 more times before I claim ownership.
And then it's yours. Right.
But I think it's so essential, and those that are really good at data are really good at listening. And I love the way you are building into a sensitive and thoughtful ear. Kind of said differently, you're building EQ into this system, and that's a critical component in the work we do. Carissa, before you joined Insight and Health, you have the social worker background. So I'm very interested in hearing about gaps in services that you observed.
Yeah, absolutely. I could pretty much say ditto to everything Ezekiel just said, but I'll add to it just a little bit. Rick, you always talk about needing to sort of get to the root cause of things and understanding why someone is hungry. And I think what we started to observe in the healthcare space was that the message is important. You can kind of message, anything out. You have this benefit, this transportation benefit, food benefit, put it on a postcard, mail that out. What we forgot was important is the messenger and the conduit and where that is coming from and what that communication modality is. As a boots on the ground social worker, I learned so much more about individuals being in their home, watching the food choices that they make, observing the conversations happening while they're cooking dinner. That experience, it doesn't translate to getting a frozen meal in the mail that you pop in the microwave. That same experience doesn't happen there. And what I found as a clinician when I worked for a health plan, and Michael and I talk about this all the time, is just innately health insurance isn't necessarily the most widely trusted industry. And so I no longer had the luxury that I had as a boots on the ground social worker of having that person just kind of trust me from jump. So really the importance of establishing a solid relationship and rapport was huge for me in that space.
Yeah, it's, you bring up a good point before we jump into this next section, which I'm really excited about. I think we often approach this word experience, and I hope everyone's listening. And so I'm this do-gooder, not-for-profit guy, so I can say it. But if you are translating that word experience as in a Disney-like way, we got to give them something. Oh, we just got to give them some food. And you have kind of narrowed down in this particular case that it's just food. Then you miss the point. Food is a medium. It's a vehicle that opens up a social connection. And at U.S. Hunger, we really use that because we provide it discreetly. As Ezekiel mentioned, it doesn't look like food help. We send organic, fresh, straight from the farm food. That immediately says, oh, this is different. They care. And oftentimes what we don't realize is we use currency to exchange goods. And often this population data is the currency that exchange goods. So they already know if you just want something or you want information. So they're not going to easily tell you what you want, what you think you want. They know you're after something. And often I believe just from, the work we do at U.S. Hunger, that, engagement is actually easy if they know you care. And we use food as that medium to say, tell us what's really going on. What do you need and how can we help? And so I just think we need to really reframe this word experience and engagement. It is not providing them a wow factor. It is really getting behind their experience and letting that experience inform our next step. So I'm off my soapbox. So I want to jump into this next section. I'm really excited about it. So often technology and nonprofit are not words that you typically hear together, but we're not typical nonprofit here at U.S. Hunger. And last year, in the midst of this pandemic, we made the decision to really invest in our technology and prioritize data. And we've had amazing partners like JP Morgan and their Force for Good team come alongside us in that effort. And this year, Ezekiel joined us as our CTO and is building out a SaaS platform that uses predictive analytics and native language processing and machine learning stuff I didn't even know how to spell to solve food insecurity. And you go, "Oh, that doesn't seem to go together," but it does. And this has allowed us to really integrate and partner better with healthcare organizations like Insighten and other partners that we work with. And I'm excited about this conversation here. So I've asked Michael and Ezekiel to walk through their data observations for a particular county. In this case, we chose Cook County, Illinois. So this is a live discourse, and then they will collaborate in real time on their observations. So Michael, let's start with your findings.
Sure, thanks, Rick. So I think one of the interesting things here is, as Rick said, is you've got a population from the health plan perspective that there are knowns and unknowns, and a lot of the time there may be a question as to whether somebody, for instance, has a barrier to health that might not be confirmed. The health plan might not know. So part of the kind of the trick here as well is understanding what the data is telling you and what you might be able to infer from that data to be able to really manage your population in a much better way. So looking at Cook County, as we see here on the screen, our analysis there in our platform, there's just shy of 92,000 members. Now, obviously, that's a lot of people, and there's a lot of different populations within those 91,000. So how do we get to a point of making that population more manageable, but also actionable with something that is a real issue? So just by drilling down that population and being able to kind of peel back the onion and see what the real issue is, what we can see from that is out of the almost 92,000 people there, we've got about 4,800 that we've identified as having some sort of food insecurity issue. Now, that might be real, as in the health plan knows they have because, somebody's put in a Z code or something like that. Or it could just be that actually this person in this population looks very similar to this person over here. And so let's ask the question. Let's just reach out and ask the question and find out if they've got an issue. So from that 4,800, then you start to look at other things that might be affecting or even might just be a contributing factor to that food insecurity. And there we look at, well, okay, comorbidities. Who has diabetes out of that group? We know that, just from speaking to Ezekiel last week, I know that there are upticks in the amount of diabetics in the population at the moment. So understanding that as a trigger and as another separation allows us then to say, okay, this person's got food insecurity question, and we know that they have diabetes. So from that, you can start to see a more workable population. Then when we overlay another kind of health inequality there, which is transportation and the ability to actually get to a grocery store or to a pharmacy or even to your doctor, we can narrow that down to a group of 333 people. So looking at that now, you've got a much more manageable group to be able to actually confirm, hey, is there an issue here? If there is, that's where you can leverage your supplemental benefits to try and remove that barrier and to get them more engaged. So I think that kind of delineation of big to small and really being able to microscopically kind of look at your population and understand some of those triggers is really important.
Yeah, I would just add to that and say, Michael, established players, healthcare providers, managed services, hospitals, data research groups, we're not even going to try as a nonprofit to reproduce that. It makes no sense at all.
Yep.
But what I can say is that we're really good at knowing what's going on with people, right? Because we see them and interact with them on a just-in-time basis much of the time. So the missing piece to such a comprehensive view of data and populations like you have here is what's happening today. What happened yesterday?
Yep.
What might happen next week based on a shorter trend line? So we took a look at Cook County, Illinois, and we pulled it up on our geomapping. And we had a sample size there. We have 861 applicants in Cook County between 2020 and 2021. And we took a look at that population of people. That's what those red clusters, those red dots mean. Those are people that have asked us for food assistance. So we drilled down and we took a look in the gauge cluster that we came up with, similar to what Michael just did, shows that out of the applicant population, I want to be careful to distinguish, okay? We're talking about a specific population, whereas Michael was dealing with an entire population. Just a magnificent job of that. So we're going to try to do a great job at looking at specific population. In this case, almost 70% of them have chronic illness. It's just it's mind-boggling to me in this population that basically 3 out of every 4 have serious debilitating illness. Virtually all of them who applied for assistance live in a food desert as defined by the USDA and other agencies, low accessibility. So in the urban areas, once you get outside of 1 to 2 miles, that's considered a food desert. And when you have people who are chronically ill, what's the likelihood they're going to get on a bus and take a drive to the local or take a ride to the local supermarket on the bus or transit system, get fresh vegetables and food? They have chronic illness, which usually means inflammation, hypertension, diabetes, arthritis, cancer, possibly. They're in a food desert and we expect them to eat better. It's not going to happen. That's the reality of it. And to make it worse, we often exacerbate the problem. And I just want, Michael, I may want to pull you in on this point of an emergency response versus a sustained response, right? A doctor gives sustained response. An organization like us, we give an emergency response. Very often with our emergency responses, we're adding fuel to the fire because we may be giving them dry goods. We may not be giving them fruit and vegetables, although we do now, U.S. Hunger does. But a lot of organizations are giving dry goods in cans, the salt bombs, the fat bombs, the hard bombs, right? And you're driving people right back into the hospital. But bless our hearts, we're trying to do everything we can to help them, but they live in a food desert. So it's going to take a totally different approach to get good nutrition to them. And additionally, almost another 2/3 of them live in low-income census tracts. That's a geopolitical, socioeconomic issue, but it helps decision makers make better decisions about where we allocate funds and what the root causes of hunger and sickness are. So, Michael, I just wanted to pull you in on that point about how we could collaborate better together.
Yeah, Ezekiel, I think I think you hit the nail on the head there in terms of, and actually Carissa mentioned it earlier on as well. You know, I think it's Forrester Research did some kind of calculation on trust in the healthcare industry, and payers in particular there's a very low trust bar there, and so for payers to be active in the community, I believe it's about leveraging those community partners and those non-profit organizations such as yourself. They should be the front line because they already have the trust. They've already got the buy-in from the community, and that emergency response is what's needed at the time. And they're a trusted advocate for that community. I think where the health plan can then pick up the ball and run, as it were, is okay. What happens next? How do we actually, change that emergency response into, as you said, Ezekiel, more of a sustained response over time? And in doing that, then the health plan can build trust with its community. And going back to experience, that right there is, I think, the key to, delivering great experience is, being able to really challenge some of those and tackle some of those barriers in your community and make everybody in the process healthier and happier. I think that's where we can draw on each other's strengths and use our data to drive those better outcomes.
Yeah, I agree with you 1,000%. And I have some observations here that we pulled out of our data sets. And I will set Carissa up to give some insight. I'm going to talk through a couple of them quickly, and then I want to just flip it to her. But we did a 2-year trend analysis, a comparison of the top 10 chronic illnesses in Cook County that we have in the applicant population. In 2020, the top 10, you can see the usual suspects: diabetes, hypertension, arthritis, cholesterol, COVID, obviously in the heat of the pandemic. But when you look at 2021, something's very surprising happened current day. If we treat this data as the edge or the tip of a discovery knife, right? We took a sample and found out, whoa, obesity, that's not even in the top 10 last year. What does that mean? It means people may be stressed out. They're eating lots of bad stuff because, as you can see, cholesterol shot up to number 2 in that population group. And so there's a lot of context here that we miss because people are not going to necessarily tell you these things like, yeah, I eat too many chips because we don't have enough good food, or I can't get to the grocery store. But this kind of data uncovers that. And as we look at the next slide, we wanted to take a look at basically couplets, triplets, doublets of chronic illness. And Chris, I'm going to ask you to jump in here for a second. When we looked at the most common pairs we found in our data sets for Cook County, we saw arthritis and others. So there's a lot of chronic illness with joint pain and that sort of thing. You can't expect these people to really get out and go get food. Then diabetes and hypertension, both. I mean, that's a killer combo, literally. And that is, and then diabetes again with arthritis, which was in the number 1 spot. And it just, so I'd be interested, Chris, in what your take on this is about this population.
Yeah, absolutely. So the two things that jump out at me are, and you started to touch on this, the need to begin to have more organic conversations with people around these topics. So, you noticed a jump, year over year, and a lot has changed in the world during that time. And so I think some of the people who may have afflictions in new areas that they're not used to because of the world changing may not kind of know how to articulate that. And I know depression isn't on here, but I think of it as very similar to that, because if you were to ask somebody those typical healthcare questions, they're called the PHQ-2. Are you down, depressed, or hopeless? And do you have loss of interest or pleasure in doing things? And you can see just right there, that's a very clinical way of asking. Same thing as asking what's your A1C, how much do you weigh? Those are very clinical questions. And so you can't even really begin to understand maybe some of the things that someone might be at risk of until you can have the conversation with them in a way in which they can engage. So instead of saying, are you down, depressed, and hopeless, ask them about, what's your sleep patterns like? Do you find yourself sleeping more now, less now? What's your activity level like? Around the A1C, those are terms that help us, people out there in the healthcare field. They're not terms that are there for the member, but tell me about a typical day, what you eat for breakfast, lunch, and dinner, how often. Just having very natural conversations will allow us to kind of understand this population better and some of those compounding factors, underlying factors. But the other thing that stands out to me here is that I think sometimes the typical healthcare response is to look at these as symptoms and address them as such. And I know we've had a lot of discussion about Maslow's hierarchy of needs. And to your point, we can't get to an individual really, nor should we try to get to an individual caring about what's my A1C if I don't know where I'm going to sleep tonight, what kind of food I'm going to get, the food that I'm getting isn't the right kind of food to really allow me to live my best life. So those two things really stand out to me, is the need to address the basic needs first, and a need to also really have those conversations that allow people, to use your word, Ezekiel, that dignity to disclose where they need help.
Hey, Ezekiel.
Yes, go ahead.
And I'm surely the dumbest person in this row here of smart people, but what stood out to me is when you and I started talking about this trend difference in the self-reported illnesses. It was around March that we saw obesity shoot up. So, I mean, within 3 months of coming out of the first year of pandemic, actually, right at the anniversary year of the pandemic, we saw obesity over the overall national population really spike up tremendously. And I think it's not just the good work a nonprofit does, but it's having someone like you on staff and really beginning to use that interchange of providing a need as a point of understanding. And we often say, for us, it's food is a medium to understanding what's going on. So I love how we're having this longitudinal conversation and a just-in-time conversation to really show actually what's happening and what is progressing in current real time. So it's just fascinating. I wanted to add that.
Yeah, and I want to tag my buddy Michael in, because he had a really interesting take on collaborative efforts between for-profit and not-for-profit organizations, that holistically we can make a much bigger dent by more effectively working together. I made the comment to Michael that I see nonprofits as the canary in the coal mine. And I think everybody's familiar with that particular symbolic example, right? We can tell you when things are going really south. This is an example. We're telling you this is what we're seeing in the population. I don't know what the trend was over the last 5 years. Michael and his group would know, but this is what we see happening right now. We see obesity shooting up the chart. So I see the role of nonprofit organizations being more of a canary in a coal mine.
Absolutely, Ezekiel. I think, and I think the key there is it's the data to know that that's happening, but it's the timeliness of that data. A lot of the time, the health plan's responding to an event that's probably already passed, or, it's not critical at the time. And I think that just being able to understand, and as you said, it is the canary in the coal mine. It's that early warning kind of, alarm that goes off to say, hey, there's a problem in this particular community that you need to be aware of. This is happening. And then I think and that is a great enabler for the plan to then be able to plan a response and do it without the kind of, do it methodically and not necessarily because there's an immediate need and it's got to get out there straight away. Working together and actually using that data timeliness as a way of serving that community, I think is, that's going to be key moving forward. I think, enabling community partners and nonprofits to be able to plug in to that data ecosystem, and for that data to be back and forth, I think is just it's key. It's going to be key moving forward because it's going to take a village, well, in fact, it's going to take a whole city to really change the paradigm.
Yeah, and I really appreciate your expertise of both of you, because it helps me, right, as a technology officer for a nonprofit. It helps me and counterparts like me, other peers, narrow our mission in even more using technology and data to tell other players, to tell you guys what you need to know in order to serve people more effectively for that sustained response. Carissa, I wanted to tag you back in because I know you haven't seen this, but I just want to put you on the spot and ask you, when you look at this word cloud for these applicants in Cook County that we have, what's the story you see here? What's the voice in this data that you see here?
So two of the words that really stand out to me that are maybe outside of the obvious. COVID obviously stands out because that's the world that we're going through now. But I see family there. And I think what we started to talk about that is what I love the most about the service that you all provide is that idea of preserving the integrity of those family traditions, that you can open that box of food from the U.S. Hunger and you can make a meal together. And those conversations that happen during that process get to a level that is deeper than might just happen, even just sitting at the dinner table, because you're doing two things at once. And so you're just really speaking from the heart there. So family standing out to me. Also pay, work, and worry. Because one of the things that I think we've talked about before is, I could put I could build someone an apartment in a Whole Foods, but that is a mere tactic. I'm trying to good-naturedly, good-heartedly throw a solution at a problem. But if that solution is not a practical one, it's not within reach, it's not a solution. And in fact, it's something that can undermine the pride and the dignity that a person has. So I think it is so important to think about the messages that we're sending without even knowing we're sending them when we're intervening.
Agree. And
Brittany?
additionally, Carissa, I still want more input from you because, again, you haven't had a chance to see this, and Michael and I previewed it a little, but I'd love to just hear your reaction to this story. And what we did was, this is an example of the free-form story text journey that people give us, right? We got over close to 80,000 of these. And what we did was we highlighted the word cloud most frequently occurring.
Mm-hmm.
What's your impression of this story?
This is such a, and I'm reading through it here. Really, really, truly, folks, this is my first time. So it's the organic impressions. But immediately, this is such a traditional story, especially when I'm reading about the SNAP benefits being not enough. It is, I feel like I can say this as a social worker. We come from such a good meaning, well-hearted place, and we have these great benefits. But until we really start to dig into the data, answer the question of why, answer the question of kind of how did we get here, the interventions can easily fall flat. And you can see this is somebody who is dealing with so much, loss of employment, the right kind of food that is needed in order to help kind of proactively address conditions. They're expensive. And, again, we can talk, there's tons of resources out there, but sometimes those resources are seemingly unattainable because you get to the food bank and the line is so long. What stands out to me is that this is everybody's story. This is this person's story, but there are so many people who this is really truly the struggles that they face day in and day out. So it's why agencies such as yours are so important, and the data analytics to power it to do the most good is so important.
Yeah, I'd love to tell you that this is just one of those stories, but as you heard Ezekiel allude to, we have almost 80,000 of these. And what's, I think I want to point out as well is these are organic stories. We don't market or solicit. These are people who have a need. And as you can see with the overlap of chronic illnesses, can't often get out. And so they're searching for a Amazon-like, a Blue Apron-like experience that normally not quite in their reach. And I think there is so much power in this. I saw one of our viewers, Susan, I didn't catch the last name, make a comment about, there it is, how important it is for partners to be a participant in the data results, and the family themselves, right? And just say this loud and clear again, I'm the guy who doesn't know anything, but there's a really, really fine line between and analysis and presumption. And not getting that right gets health wrong, gets ROI wrong for the executives that may be listening. You get it all wrong, and we don't really solve the problem. And what we have figured out, just as the pandemic slap in the face when your world gets turned upside down, is that, we were missing an opportunity, and I hope other nonprofits hear this. We were really missing an opportunity to use that point of exchange and the service that we were providing as an opportunity to deliver what the best brand across the world know how to deliver: the Starbucks, the Macy's, the JP Morgan, all of those folks. Here's what they know: you give best experience and interaction, and that's why our food is organic and from the farm often, and it's farm to table, and yes, it's expensive, but it really makes this statement about dignity that's critical. A lot of people use that as a catchphrase, but what it really means is I give you what I give my mom. You don't get
Yeah.
back of the pantry. You get front of the pantry. You get what's in the fridge, actually. And that's important for us, but it starts a meaningful engagement. And the starting position for us is one of care and trust. And again, this population often knows when you want something. One, because they've never heard from you before. And we've just learned that U.S. hunger is just a using what we do as a point of connection is the great first place to start engagement. And if you're trying to figure out engagement and experience, but your point of connection is late, delayed, often ignored, or it just sucks, your ability to build a platform of engagement and experience is going to be different. And nonprofits around the world understand that really well. And so we're trying to take the best of that world, but also the best of cutting edge technology and data to really build and bridge partnerships like this and others. Let me go to my third question. We're rounding out some time, and I want to leave a few minutes for questions. So our data has shown us that hunger is not about food, but it is the root cause of almost every hunger story. And that always has to do with a social determinant of health. So hunger is a great weather vane for SDOH. And here's what I mean by that. You can't determine the strength of a house by its roof. You must always look at its foundation, and food and water and shelter are foundational to Maslow's hierarchy of need. And so understanding what drives hunger, we've learned, and the data has suggested to us, almost always leads to a clear view of social determinants of health. And it's why, as a nonprofit, we've made this decision to take a data-driven approach to strategic partnership. So, Chris, I want to start with you this time. How do you see health plans using this type of technology and in collaboration to improve health outcomes for members?
Yeah, great question. So a couple of things come to mind. First is around resource allocation. And so, we have to, health plans, the fact of the matter is there's still individuals who are needing to run a business and be able to stay afloat in order to serve the people who they want to. And so beginning to take a look at this data and understanding what is the right resource to allocate here. So we may identify individuals who live in a food desert for whom the best or the next best action, the best first step is to connect them with an organization such as yours, or with a community-based resource, social worker, someone of that nature, to really start to kind of address those foundational levels, so that then some of those other resources, the physicians, the nurses, we can really leverage those resources in the most impactful way, and having those individuals work with members when they're at a place where they're ready to have those conversations. I think that's number one. But I also think that data allows us to sort of hyper personalize that experience. So, I had talked about boots on the ground. I really felt like I could connect because I was having these in-depth conversations. That AI can begin to help, clinicians, health plans really get a better, more holistic, comprehensive picture of what's going on with that individual, so that the message is delivered by the right vehicle, the right communication channel, the right type of messenger, back to that kind of messenger concept. So those are the two things that stand out most for me around health plan utilization of this kind of data.
Letting the voice of the patient, the member, the family member drive the response. It seems logical, right? It makes a lot of sense. Michael, just listening from that exchange with you and Chris and Ezekiel in the data section we just ended, member data just seems critical to meaningful engagement. How does working with a nonprofit focused on real-time data like U.S. Hunger and others change the landscape of how the health sector approaches SDOH?
I think it's key in first of all identifying that there's an issue. I think it enables much more rapid response and a much better sustained response as well to that, to kind of working together. I think the other side there as well is that, as we talked about earlier on, the fact that experience is becoming such a big key. I think it's about putting the right players in the right spots, so that you can basically leverage those relationships. And at the end of the day, it's really going to end up being a more hyper-local kind of delivery, where you're understanding both what's happening at community level, and up from there. And the health plan then can use that data to build and design better products for its members in the future. So really getting down to that, what is the thing that on this particular street or this particular neighborhood might actually solve some of those underlying issues that we're seeing? And it gives them the ability to do that, and to actually change their offerings, ultimately for those communities.
Yeah, as you say it that way, it's almost building very real-time street level personas that you get to watch the evolution of that persona in the moment. That's fascinating. I hadn't really thought of it in that way. Ezekiel, I've heard you say often that our technological mission at US Hunger is to improve the core competency of technology and data for the nonprofit sector.
Across the entire country. That's the goal.
So 2 questions for you on that. First, what does that mean? But then second, how can US Hunger's platform aid in the work other nonprofits are doing to address social and economic issues? I know you and your team are working on that furiously.
Yeah. Well, on the first part of it, what does that mean, raising the core competency? The short, quick answer, so we leave time for Q&A. The short and precise answer is the number one weakness of nonprofit organizations is the inability to articulate what just happened. It's not recorded. It's not in one place where it can be combed through and analyzed. It's in spreadsheets. It's in Word documents. It's everywhere. And so my heart, because I've worked with nonprofits before, they have the biggest hearts in the world. And in an emergency situation, you want the nonprofits mobilized. I don't care what kind of food you get me. If God forbid, but if I'm in an earthquake zone, you give me carb bombs, you give me sugar bombs, salt bombs, you give me corn, you give me potatoes. I don't care. Hook me up so that I don't die of starvation. Bring me water too. And thank you. So these organizations are key to keeping the country in a stable position when things go really south.
Yeah.
Now, the flip side of that is, since we're not equipped to deal with years or decades of data, actuarial kinds of stuff, that's not our expertise. Be the canary in the coal mine, emergency response, and raising the core competency means that when someone asks you, where did the food go? Who did it go to? Who are the people that it went to? What is their story? So we can improve and plan for them going forward, right? Because there's a recovery period. By raising the competency of all nonprofits to be able to articulate those questions and answer them, we've helped the entire country and eventually the world. So that's what I mean by that. The second part, how can our SaaS help people? Well, our goal is to give it away. I mean, our mission is to give it away or get people to sponsor it. Obviously, we got to keep the lights on and that kind of thing. But the ability to provide access to the platform to others, either by just having a simple account, like you'd have a bank account, you can log into the US Hunger SaaS, it's branded as yours and all that kind of good stuff, and you can see all your stuff. But you have the data, you have the analytics, you have the machine learning, you have the AI, because we've built it for you already. And all you have to do is use it to continue doing that great work that you're doing. That's essentially what we're after. And if somebody wants to roll their own, we can consult with them and give away the knowledge and the understanding of how do you pivot your organization, like Rick did ours, in a year to go after this new paradigm. Because as Microsoft CEO says, if you are an organization, you are now a software company in this day and age. There's no way around it. So we want to enable our partners in the nonprofit space to do that effectively.
Well, I love your heart around that, Ezekiel. So the nonprofit guys coming out here, if that appeals to anyone and you're interested, we are really thinking about how can we pool together resources to license back out to other nonprofits. So if you're thinking about a nonprofit that you engage with heavily at a local or regional level, and you want to help them improve on that just-in-time data, we have lived on that system through a very difficult time in the world, and our whole goal has been to license that out. And we're excited. We'll soon be onboarding our first nonprofit client pretty soon here before the year's out. So we'd love to talk to you. All right, time for questions. So if there are any, let's just pop them on the screen. So here's the first one. So many interdependencies between hunger and health. Food insecurity is a symptom of a larger systematic disease. How do we make the turn from just treating the symptoms to truly curing the disease? So clearly we're not starting with an easy question. I'll open it up to the panel. Ezekiel, why don't we start with you, since you have that pulse of what you're seeing right now around hunger, and then others jump in.
Okay, just real quickly, when Michael said food insecurity is a symptom of a larger systemic disease, you are absolutely correct, sir. It is social determinants of health driven. How are you feeling? How are you living? Do you have a support system? How do you feel about yourself? Are you happy? Are you healthy? Those sorts of things. And no matter how you collateralize that with official designations, the issue is people are hungry for reasons usually not really related to food. We have people splitting pills. We have people skipping doctor's appointments because they don't have enough gas to make the appointment. Why don't they have enough gas to make the appointment? It's not because necessarily that they're bad stewards of their money. It's because the prescriptions are so expensive. Or to eat healthily, as the doctor has ordered, they can't because it's out of their reach, or they can't get it to their home. So how do we make the turn for just treating the symptoms to truly curing the disease? I'd say social determinants of health.
Michael, Carissa, want to jump in on that one?
Yeah, I totally agree, Ezekiel. I think there's a stat out there that is very powerful that says that 80% of all outcomes actually stem from solving a social determinant, which to me is kind of mind-blowing. But also, I think all of us around the table here would agree, yeah, that sounds about right. Because until you tackle those things, you're not really going to get to the root cause. And I think actually uncover, we all kind of know what those root causes are, but I think the more that we share that data and we use data for good, to really uncover those kind of systemic issues, I think the more then they can be highlighted and tackled as a single issue, rather than as this is just too big to solve. Let's it goes back to kind of Carissa mentioned the next best action. I look at things like through that lens a lot of the time, and to me it's like, well, let's work out the one thing that we can do here to move the needle. What's the biggest issue? Well, let's tackle that first, because and that might even be education, going right back to starting to educate children on actual food use and the benefits of being healthy from an early age. I think until you really start to tackle those hard issues, you're still going to be treating a symptom. But I think data can be used to really, drive those things out.
All right, someone's having a little mercy on us here. We got an easy question. Easier. Let's see. I am head of one of your partners in Full Cart. Can you speak a little more about how you are envisioning data sharing with your partners? Sure. So I think some of that is in a couple of ways. One, we're trying to provide a digitized onboarding process or experience for other nonprofits, and we want to license that out. And our heart is to have other sponsors grant that ability to both onboard and license. Our heart is to be a nonprofit technology. So more to come on that. We have been the best beta tester of this, having woken up by March and 90% of our revenue was gone, and we full tilted to technology, and it transformed how we think. And so from that experience, we know how that can and will transform our other nonprofit partners. So our goal is to work in that direction. So hopefully that answers some of that question. I would say stay tuned, and I would say partners, reach out and get connected to us. We are looking to be able to bring that to the nonprofit world. Next question from Alexandra, and this may be the last one we have time for. How can nonprofits ask clinical questions in a conversational way to gather more data on their populations while keeping integrity and building trust? Oof, this is a really good question.
Carissa.
It's a Carissa question.
It's $1 million question, but I love this question because I think it is almost less about the asking and more about the listening. And so, even just asking people, again, I think I had started with how are you sleeping is just such a great indicator. Because people will begin to talk to you then about what is maybe getting in the way of a good night's sleep. What do you like to do? What do you find enjoyment in? How do you spend your time? And allowing that person to talk and to just kind of listen, make eye contact where possible in Zoom and whatnot, and really provide those just encouraging cues to keep talking, because what you'll find is people will then organically tell you things like, I'm not eating so healthy right now. I don't really want to get out of bed. I have to force myself to. Sometimes I don't see people for a number of days, and you can start to uncover there's social isolation going on here. There might be depression happening here. There's just a lot you can get by simply listening. So I think the less clinical you make the question, the more likely to elicit an organic response that is very telling and allows for that great helping, trusting relationship to happen.
So I'm going to say it. My team's probably going to eyeball roll in a second because I always say it. And I'm like, what? I think we make this way too hard. Oftentimes, particularly in the healthcare sector, and the reason this series is about health and hunger is because we figured out hunger is a weather vane to what's driving health. We get so focused on the clinical what, we never focus on the non-clinical why. And what our data tells us, in more than or nearly 80,000 conversations, there is a socioeconomic, which is a non-clinical driver to those clinical issues. And you saw in the Cook County data, but in our larger overlapping data of the whole country, 80% of folks who find us, no marketing, no advertisement, they find us, they live in a food desert. And almost 70% of those same people, same population, report a major chronic illness. Either they have it or someone in their house, they're managing it. And so I think too often we start from an ROI perspective, which, listen, we run a missions-based business. I get that. But if we start there, we're starting where we are. Now, the ROI is based on solving the problem, but to solve the problem, you got to start at the root of where the problem is.
Yeah.
And it's that non-clinical conversation, as our data shows you, which leads to, all right, even if I talk about this, they're not going to understand it. So as we close it out, we're right at the end of time, I see here. If I could just say it this way, here's what we've learned. A food desert is a pharmacy desert, is an endocrinologist desert, is a health and parks recreation desert, is a green space desert, and the like, and the like, and the like. It's not that hard. It's not that hard. And so I think the essence and the pulse of social determinants of health and why we're so focused on it is because someone's already figured out if you get at the root of the foundation of Maslow's hierarchy of need, food, water, shelter, if you start at the base of the foundation, you'll build the right house. And I think too often we're trying to start at the top of the skyscraper, and it's just the wrong place to start. At least that's what the data tells us as we see it evolve. So Ezekiel, Michael, Carissa, thank you so much for your time today. And I hope that this has really helped the folks who's gotten a chance to listen into this conversation. If we did not get to your question, please send it out to us. Keep it coming in. We'll watch the social media threads and other mediums. Guys, thank you so much for joining us today.
Thanks
Thank you.
for